So my name is Dr. Stephen Graves. I am a medical physicist and assistant professor of radiology in the Division of Nuclear Medicine at the University of Iowa in the United States. And today the topic of discussion is radiopharmaceuticals in principle, mechanism of action, and biologic effects. The first step in designing a new radiopharmaceutical is identifying a biologic feature that is overexpressed on tumor targets. Often this is the result of many years of genetics and proteomics and preclinical work leading to the identification of a target that can be developed for drug discovery and for radiopharmaceutical development. So once a target is identified, the radiopharmaceuticals for therapy generally consist of three main components: a biological targeting vector that binds to that target in vivo, as well as a chelator that can be used to conjugate and retain a wide array of different radioisotopes for imaging and for therapy. And to bind the chelator to the targeting vector, there's often a linker which can be used to modify the overall pharmacokinetic properties of the radiopharmaceutical. So for example, making the linker a little bit longer would make the compound more lipophilic, more likely to clear by the hepatobiliary tract, and a little bit shorter would make it more hydrophilic and therefore more likely to clear by the renal pathway. So the other considerations with respect to developing a new radiopharmaceutical are what type of radiation do you want the radioisotope to emit? So we have primarily alpha emitters, primarily beta emitters, primarily gamma emitters used for imaging. We also want to consider the half-life of the radioisotope. So if it's too short, a therapy compound would have most of its radioactive decay occurring when the compound is still located in the blood, as opposed to localizing to the tumor surface and decaying proximal to the tumor cells themselves. And if the half-life is too long, although the uptake in the tumor may be avid, the dose rate may be too low to affect a meaningful accumulation of DNA damage to deactivate tumor cells within the tumor microenvironment. So we want to think about sort of an intermediate half-life for developing therapies. And we want to be mindful of daughter products. If the radioisotope decays to a radioactive daughter itself, we want to understand the biologic fate of those daughter radioisotopes. So the different radioisotopes that we use for therapy are either considered alpha emitters, which decay with the emission of a helium nucleus, these relatively large, positively charged particle, or decay by beta emission, which is the emission of a high-energy electron. And these two types of radiation interact and induce biologic effects in quite different ways. So the alpha emitter will deliver its energy along a very short path length with quite a lot of ionization in sort of a linear track, whereas the electron, the beta particle, will have a tendency to sparsely ionize and travel relatively large distances between creating clusters of ionization in the body. And as a result, the primary mode of DNA damage for alpha particles is induction of double-strand DNA breaks. So a single alpha particle traversal of a cell nucleus is likely to induce a large number of double-strand breaks in the DNA, as opposed to beta particles, which will induce small clusters of damage, primarily single-strand breaks that will build up, given adequate dose and dose rate, to lethal double-strand breaks. But it turns out that the mechanism of damage for low LET radiation is much more chemical in nature. So creating a free radical species is primarily the mode of inducing single-strand breaks. And these free radicals can diffuse and cause that damage to the DNA, but it can also be neutralized by antioxidants such as superoxide dismutase or radical scavengers, including sulfhydryl-based compounds. And then once those single-strand breaks occur, they can either be chemically repaired, or they can be made more permanent by oxygen effects, or they can be enzymatically repaired. And so in general, we think of the high LET alpha radiation as being much more damaging per unit dose, on the order of 3 to 7 times more potent in terms of cell killing in comparison with low LET beta radiation. So a real strength of using radiopharmaceuticals for therapy are that they are inherently radioactive. And it turns out that radioactivity is quite easy to detect and allows for 3D imaging after administration of a compound to an individual. So for patient-specific dosimetry, the typical workflow would be to administer either a small quantity of the therapeutic radiopharmaceutical or to administer the therapy itself, and then to take that patient and scan them with a SPECT CT scanner, single photon tomography, a few times over the course of the decay of that radiopharmaceutical, generally scanning at 24 hours, 48 hours, and maybe a 96-hour time point. And that data allows you to characterize the concentration of activity in various organs and tissues throughout the body as a function of time. And based on that, we're able to calculate the total number of radioactive decays that's occurring in normal organs as well as tumor tissues. And that allows us to compute the radiation dose. Additionally, because we have the dose rate effects, we're able to model the biologic effects of radiation, thereby allowing us to convert between, say, external beam radiotherapy dose treatment schedules and the radiopharmaceutical dose rate and dose effects, and thereby allowing us to predict the biologic effects from the radiation, and allowing us to patient tailor our treatments so that you don't exceed normal organ dose limits, and you also are able to ensure that you're able to get enough radiation dose to the tumors themselves. So although radiopharmaceutical therapies are quite effective for binding to the cancer cells and the tumor microenvironment and causing the intended effect, there are some off-target radiation-related effects to consider. So because most of these therapies are injected intravenously and into the blood supply initially, the blood perfuses the bone marrow, and the bone marrow, being a relatively proliferative tissue, tends to be more radiosensitive. So in many of these therapies, we do see some degree of myelosuppression that is not too dissimilar to other cytotoxic chemotherapies. Also, elevated radiation dose is seen in structures of clearance organs, so the kidneys and the liver, which play a role in removing radioactivity and peptides and various compounds from the blood, will see an elevated level of radiation dose, and have been observed as being treatment limiting or dose limiting in some cases. Other tissues of interest would be those that express the receptor that we're actually targeting on the tumor. So in some cases, there is some normal endogenous expression of the therapeutic target, and so in those cases, we have to be mindful. And so in terms of normal tissue effects, if the DNA damage is repaired and there's sufficient cell survival, we generally don't see any effects below a certain absorbed dose threshold. But beyond that threshold, the effects can build up. Additionally, stochastic effects occur whenever normal tissue DNA damage is misrepaired. Most of the time, DNA misrepair has no meaningful change in the biology of an individual cell lineage. However, it is possible to induce secondary malignancies, most commonly secondary hematologic malignancies, but late induction of solid tumors are theoretically possible. Radiopharmaceuticals have been quite effective and demonstrated to be effective in a number of solid cancer indications, including somatostatin receptor positive neuroendocrine tumors, metastatic castration-resistant prostate cancer, pheochromocytoma and paraganglioma, as well as a number of other indications that have been more relevant for a longer period of time. In general, these compounds are well suited to metastatic tumors because they are, again, a systemic therapy that can localize to small clusters of disease that are not necessarily visualized on radiographic imaging. Additionally, the range of the beta and alpha particles can be sufficient to induce immune response to systemic disease in the body, and therefore they are really quite flexible in treating a wide range of solid tumors, particularly metastatic disease where a local definitive therapy is not a viable treatment approach. Additionally, there are a number of radiopharmaceuticals in development. So although there have been about 4 therapies approved in the last 10 years, There are more than 50 that are currently in clinical trials and are being developed. And if a small number of those make it to clinical approval, that really will significantly improve and increase the number of types of tumors that can be treated using this paradigm.
Hello, my name is Anna Kiess, and I'm an associate professor of radiation oncology and molecular radiation sciences at Johns Hopkins University School of Medicine, and a practicing radiation oncologist at the Sidney Kimmel Cancer Center in Baltimore, Maryland. Thank you for joining me today as we take a look at radiopharmaceutical approaches in the management of adult solid tumors. Radiopharmaceuticals include agents for imaging, therapy, or both. Some agents are designed specifically for imaging, like gallium PSMA that targets the prostate-specific membrane antigen for prostate cancer, or gallium dotatate that targets the somatostatin receptor for neuroendocrine cancers. These emit positrons for PET imaging. Other agents are designed specifically for therapy, such as lutetium PSMA or lutetium dotatate, that emit beta particles or electrons that cause DNA damage for treating tumors. And we also have the ability to often directly image the therapeutic agents, such as those that are labeled with lutetium, using SPECT scans so that we can do dosimetry calculations. For clinical considerations, these agents are approved by regulatory agencies for therapy when they show efficacy and safety in a specific patient population, and there have been multiple recent regulatory approvals for various cancers. Specific patients are actually often screened for the therapy using imaging that is paired. In development, there are many new agents that are up and coming for most solid tumor types, as most solid tumors respond to radiotherapy. The development of these agents and the choosing of specific targets is related to the relative uptake in tumors versus normal tissues. So biodistribution and pharmacokinetics play a large role in determining what the final absorbed dose is to tumors versus normal tissues, and these absorbed doses are directly related to tumor response and toxicities. Most radiopharmaceutical constructs consist of three parts. It's the radionuclide itself that emits radiation, various linkers and chelators, and the ligand or ligands that bind to targets. There are a variety of different ligands that range from smallest to largest to include small molecules, peptides, minibodies, antibodies, and nanoparticles. And there are various properties that are amenable to different applications with these different ligands. So, for example, small molecules, such as lutetium PSMA, have rapid tumor uptake, rapid clearance from the bloodstream, and very good solid tumor penetration. Larger molecules like antibodies and nanoparticles have often a longer circulation time and can have specific properties that lead to tumor retention. There is some concern for these sometimes for hematologic toxicities due to the longer circulation time. Antibodies and nanoparticles can be very readily engineered to bind to multiple targets. There are also microspheres, which are not ligand targeted, but are physically targeted due to their large size. They're infused directly into specific arterial circulations and then lodge into the microvessels of tumors, such as in the liver. They can be infused into the hepatic artery for liver tumors. Radiopharmaceuticals have actually been in clinical use for decades, with the first being radioactive iodine that is given orally and taken up into thyroid cancer cells and has been integral in the management of thyroid cancer for decades. There was also bone-targeted agents such as samarium and strontium that have been used for bone metastases since the 1990s and early 2000s, as well as liver radioembolization with Y90 microspheres. In the past 10 years, we've seen the fruition of many years of development in radiochemistry and molecular biology to allow for more rapid development of small molecules and peptides targeting specific molecules for specific cancers. So this has led to the approval of multiple agents since 2013. In 2013, there was FDA approval of radium-223 for metastatic castrate-resistant prostate cancer with symptomatic bone metastases. This is a calcium analog that is taken up into areas of bone turnover and emits alpha particles. In 2018, we had approval of iodine MIBG for advanced pheochromocytoma and paraganglioma that targets the adrenaline receptor, as well as lutetium dotatate that binds the somatostatin receptor and is used for treatment of midgut neuroendocrine tumors. And then finally, just last year, we had FDA approval of lutetium PSMA 617 for metastatic castrate-resistant prostate cancer that binds the prostate-specific membrane antigen and is also a beta emitter. There are many agents in development in radiopharmaceutical therapies. For example, there are several agents that are in development that also target the somatostatin receptor and prostate-specific membrane antigen. These include other beta emitters and some agents that are labeled with alpha emitters, including actinium-225 and lead-212. Alpha emitters have a much higher density of double strand breaks in the DNA and therefore have the potential to have a more potent tumor response. They also have a shorter penetration distance that may limit certain toxicities. There are also agents in development for many new targets for solid tumors. This includes gastrin-releasing peptide receptor for GIST, breast cancer, and prostate cancer, the fibroblast activation protein, which is expressed in the tumor stroma of many solid tumors, HK2 for prostate cancer and some other solid tumors, and many, many other targets on the horizon. Radiopharmaceuticals are a naturally interdisciplinary endeavor and include the critical involvement of nuclear medicine physicians, medical oncologists, radiation oncologists, medical physicists, and radiation safety. So there are certain complexities and needs associated with this. There's international needs in terms of the availability of radionuclides and specific agents and high need and meeting supply and demand. There's also international needs in terms of the workforce and expanding education and clinical training, which is part of why we're here today. And there are logistical needs for both patient care and for research. In terms of patient care, it's often related to establishing new facilities and radiation safety measures to appropriately have radiation protection and management of radioactive waste. In research, there's a great need for investigation of radiobiology and radiation dosimetry for these agents to optimize their treatment properties and combination therapies. And altogether, these challenges are very worth addressing to bring these agents into the clinic for the treatment of our patients.